between physics, art, and math got us down this path. Historical tales come alive, where science and stories dive, blending facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Maybrick's got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire
Ramona
these
leads the way,
and ways that
explaining
make
day
me
by
more
day.
efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBix Webcast. This is Ramana Annamaraju. I'm the host. I have a very interesting guest. She is a frequent guest on the podcast. You know, she's been on the podcast. She is one of the initial supporters of this podcast. You know, thanks to her, you know, she blindly believed in me. That's why she's in the trailer also. I put her on the trailer, on my MedBix trailer. She talks about she is a highly qualified. She is a educational qualifications out of this world. She went to MIT, the bachelor's degree, and master's. She did a medical degree from UCSF, I think, and then Stanford. She's a clinical professor in Stanford right now. You know, pediatrics, and she is an entrepreneur, trailblazer, a woman champion. Just I can go on a list on that list, and importantly, she talks about sex and birth control, all those things, you know. So very interesting. She can make the life interesting here, and she's funny. And let me bring you to the table. That is Dr. Sophia Yen, joining from a few miles from here, from Sunnyvale, California. That's like Apollo, next to the Palo Alto. Let me bring you. Welcome, Sophia. Welcome, Dr. Yen.
Hey, thank you so much for having me, Ramana.
You're pro in this podcast now.
I'm an old timer.
Yeah, tell me something about your background. You know, I gave everything, but you can give me what led you to be entrepreneur. You know, most of the doctors shy away from the entrepreneurship. You jumped right inside. That's particularly, Indians are very aggressive in business, but I don't see a lot of Chinese. You know, mostly they want to work for somebody, and they do. So tell me a little bit about that.
Yeah, I think I have entrepreneurship in my blood. My grandparents had their own company in their small little city in Taiwan, Jiayi, and they also had one branch in Taipei. It was a clothing company called Birdie that made men's shirts and men's pants. And then my parents did their own startup. They both didn't intend to do it. My mom was a nurse. My dad was a PhD. And then my dad worked for a chip manufacturing company, went to a conference, and his friend's like, I bet you can't make that. And my dad goes into the garage. You know, back in the day, all the startups started in the garage. And literally, he's a chemist with his Erlenmeyer flask and chemicals and a hot plate, makes the product. And then my mom has the EQ. So she goes door to door to 3M, Motorola, IBM, and sells the product. So between
You mean to say he makes the chips on the garage?
He made this thing that I called high-tech saran wrap, which is a pellicle, and it's used in the chip manufacturing process.
Okay.
And eventually they had to put it in a clean room. And so they have their office in Sunnyvale, California. And that, I think, let me see entrepreneurship. I also saw that, at 5 years is when an entrepreneur almost dies, and what that can do to a marriage and the stress that it can put on your life. So I wasn't very excited to go into entrepreneurship, but I saw a problem, I saw the obvious solution, and my friend and I were like, well, let's make this happen. Let's make this women founded, women led. And that's why we started Pandia Health.
Yeah, that's so. Pandia, what is the Pandia means? Let us start with that one first. What does that mean? And what is
Thank
the
you.
definition of Pandia for
Yes.
outsiders?
So we purposely chose Pandia Health. We went through all of the Greek goddesses and looked at, does anybody own her website, and does her mission fit our mission? And Pandia is the Greek goddess of healing, light, full moon, because we're all about women's empowerment. And then everybody kept saying Panda Health. And so I made up the definition. Pan is every, Dia is day. We want to be with you every day from age 2 years after your first period until your last breath. Now that we've added on menopause, and most people believe that you should be on menopause HRT. A lot of menopause society certified practitioners are like, you're going to have to take this patch off my dead body because it's that useful for blood, brain, and bones.
Let me talk about a little bit about menopause. I remember when I was a kid, my mother was suffering from this one. I didn't even understand. She was bleeding, nonstop bleeding, and I didn't understand all those things. At the time, we just ignored it. She was complaining every day. Really, we are from a small village in India, rural village. My father is a doctor. I mean, not like MD like you. It's the doctor, foot doctor from that village. So he is treating as much as he can. I think that now I remember that their struggle. Now I can feel it. What that my mother went through. Really,
Yes.
she passed away. But tell us that all over the world, what the women go through, the kind of menopause. What are the symptoms, pre-symptoms, and then talk about the extreme symptoms and what are the outcomes. What are the bad outcomes? We'll talk about it first. Let us talk about that a little bit.
Yeah, exactly. Should we jump into my slides, or do you
Yeah,
just want to talk?
I can bring it.
That would be great.
I'm going to bring your slides just to give me.
That would help with the discussion.
Yeah. Yeah.
So,
Okay.
I think people should be clear that menopause is defined as 12 months of not having a period, but that period leading up to that is called perimenopause, which is potentially 5 to 10 years, but on average 5 years before menopause, where the hormones are up and down, up and down, up and down, and then up to that 1 year after that last period. And for women that are going through it, it's very difficult because you have a period and you're like, yay, no period. And then 3 months later, oh, you get a period and you have to restart the clock because it's not until a year after that we call that menopause. And so here are some very important statistics for everybody to know. There is the Menopause Society, which certifies practitioners as to having basic menopause knowledge. And there's only 3,000 Menopause Society certified practitioners. So that number is growing every, I think, twice a year because there's more people taking the test now. It's become a hot thing, but only 3,000 for all of North America. There are 1 million women in the United States alone going through menopause, entering menopause each year. And 100% of women will go through menopause. 70% of them will have some symptom. And if that symptom is hot flashes, on average, that lasts 7 years. When I graduated medical school 30 plus years ago, this is how we were taught to treat menopause. You put your hand on her shoulder and you go, this will pass. Hashtag suck it up. And would we do that to a man and be like, ha ha ha, you have problems? Suck it up. No, we would immediately go find a drug and try to figure out how to fix this. But for women, we're like, okay, and we just walk away. What's impressive is we now know with hormone replacement therapy or with estrogen.
Sophia, 1 second, if I interrupt you. You said that risk factors. It scares me. That is, you have a heart problem. It creates heart disease. It creates a colon cancer. And you're talking about. Tell us a little bit about that. What if you're untreated? Because millions of women in the world are untreated of this disease. Tell us a little bit about that.
So what happens, again, I was a biology major at MIT. I went to UCSF and currently I'm at Stanford. And using, the biological look at it is that you pop out a whole bunch of eggs, you make a bunch of babies, you stay around and help society for a little bit. But around age 52, your body stops making eggs. It takes away your estrogen. And my interpretation of that is it takes away your estrogen and it's like, thank you for your service. Goodbye. Anything above 52 is gravy. Anything above 52, we need to biohack. So as soon as it starts taking away that estrogen, and it's not that one day, but before it and after it, our bone density immediately goes down 50% within like 5 years. So 60% of fractures could be prevented if everybody that lost estrogen got their estrogen back. When you take away that estrogen, I like to say a woman's arteries turn from a woman artery to man artery. The whole reason they started HRT was they noticed that women had our heart attacks 10 years after men, and they thought it was estrogen. So what they did is they're like, well, if we give women estrogen when it goes away, will that decrease heart attacks? And they've shown that those women who get treated with estrogen have decreased heart disease. And the mechanism is when you take away the estrogen, the artery doesn't dilate and the artery fills up with bad cholesterol. And so if you put back the estrogen, then it maintains the ability to dilate and it maintains the good cholesterol.
So what is this big equations up here?
All
This is
these
a very,
equations.
you need to do you have a lot of slides. You need to go fast a little bit. Yeah,
Yes,
go ahead.
yes. So, definition, just want, everybody technically, menopause is technically just one day and everything after is post-menopause. But when you talk about menopause, most people mean after that last period. But your doctor is going to ask you, when was your last period? So you need to know that date. And it's confirmed 12 months after. And I want you all to know, because there are a ton of people coming to this for profit, and they're going to try to freak you out and say you could start menopause or perimenopause starting age 30. No, okay? Anything is possible, and there are random mutants, and there are people who will have their ovaries taken out or chemically castrated. That is the exception, not the rule. If you haven't been surgically or chemically castrated or put into menopause in an artificial way, don't expect your menopause or perimenopause to start at age 30. So these are the different hormonal changes. You'll see puberty is the rise of hormones. Your fertile years, you have estrogen and progesterone. Perimenopause is the period leading up to that last period. And note, the hormones are up and down, up and down, up and down. And so it's really important because people are learning about menopause and estrogen replacement therapy. And they're like, I want estrogen replacement therapy during perimenopause. But if your estrogen's high and I add more estrogen, that's not good. You're going to have more side effects. So it's actually better in perimenopause to take over that system, calm it down rather than have up and down. The symptoms of menopause.
So there's nothing to prevent. Let me introduce, I think, better questions to be asked by my good friend. She is Jennifer Nehmeyer. She is my partner in crime. She helped me to write a book. I hope she is in the menopausal state. I don't know much about it, so she can tell you more. So she can ask questions a little bit. Yes, Jennifer, she's joining from Dallas, Texas. So Jennifer, go ahead. Anything you want to say, ask questions. Because this is symptoms. She said that. One more question I wanted to ask you before, if she has any questions for Jennifer. You said that perimenopause, you cannot treat anything, just let the system, nature takes over. So there is no preventive way. Menopause symptoms, you cannot pre-predict and reduce that process.
Well, I actually personally believe that you can go into menopause on hormones. So the gold standard of treatment for perimenopause, this chaos, is to take it over and flatten it with the birth control pill patch ring. And so people that are learning about menopause get very upset when we recommend in the perimenopause phase, where it's chaos, to take it over with the birth control pill to calm it down. But I want to educate your watchers and listeners that that is the current gold standard. So don't be upset when doctors say, hey, let's take over this chaos with a stable level of hormone with the birth control pill patch ring. These are a lot of the symptoms of menopause, and each person can have different ones, though certainly if your mom had certain symptoms, more likely that you will have certain symptoms. The classic symptoms are hot flashes, irregular periods, painful sex. I call it sandpaper vagina, recurrent urinary tract infections. Some urogynecologists say that anybody age 52 and older who was born with a vagina should just start estrogen to prevent recurrent urinary tract infections. And the mechanism there is when your vagina dries up, your urethra, where urine comes out, also dries up, and that increases your risk of urinary tract infection. But if you add estrogen, then it doesn't, and then you decrease your risk of urinary tract infection.
Yes, I have a nerdy question for you, Sophia. Is there any predictive analytics? Silicon Valley guy, I'm asking, is there any predictive analytics can do, but when they're going to be, are there any biosensors we can predict these menopause, when is going to occur this exactly, the date and time?
We definitely cannot pin down the date and time, but we are definitely looking for a biomarker. And some people look at anti-Mullerian hormone to look at your ovarian reserve, but we need more money and more research. My joke, though, is for me, anybody who's like 50 right now, we don't have time to wait for that research. By the time that research comes, I will have a stroke, a heart attack, and dementia. So we have to biohack now.
Okay. Okay, go ahead. You want to ask any question, Jennifer?
I might wait till Dr. Yen finishes.
Yeah, let her finish. Yeah.
Let me run through, these slides, but feel free to jump in anywhere. I just wanted to go over a layman term, flooding, because this is not a medical term, but flooding, I think lay people get the largest period you've ever had in your life. And a physician would describe that as heavy menstrual bleeding. And heavy means heavy flow for 3+ days or longer than 8+ days. And 1 out of 5 women will experience this. I personally had 3 friends, not I heard about, but 3 friends that went through this. And I only learned about it now. If I'd known about it at the time, I would have helped them. But one woman couldn't visit any friends for a month because she was afraid if she sat down on their couch or chair, she would destroy their furniture. So if you are in this state, please see a doctor. We have something to decrease that bleeding. Do not put yourself through that blood loss and risk anemia, transfusion, and embarrassment. We have medications. I'm a doctor. I believe in drugs. I believe in science. Please let us help you. # stop sucking it up. Next slide.
Yeah.
The next
The reason
slide.
I stop it there, I told you about my mother, right? She went through a little bit of that suffering.
Yes. And sometimes that heavy menstrual bleeding is related to fibroids and polyps. And in that case, our medicine may not be enough to, turn it all off. It may require surgery if the fibroid is big enough. And then because of this blood loss, a lot of people feel fatigue or just in general in menopause because of hot flashes, night sweats, 27% feel worn out. And then the other one, we've seen women get what called, the $1 million workup for palpitations because they're worried that she's having a heart attack. 46% of menopause women at some point will have this sudden, like your heart is really fast. And some of them will experience it as a panic attack. Others will think it's some sort of heart arrhythmia and get this workup. And if they were on the birth control pill patch ring, we could probably decrease that incidence because they would have the estrogen and the progesterone there to help them get through this. I just want to educate people the FDA approved reasons for HRT for menopause, because as a telemedicine company, these are the only things we can treat. If you see a doctor in person and they feel comfortable, they can go off label. But these are the only on-label reasons that we can treat, which is genital urinary symptoms of menopause, urinary frequency, vaginal dryness, painful sex, risk for recurrent urinary tract infections, hot flashes, night sweats, and at risk for osteoporosis. My joke there is, as minorities, we never get a leg up on anything. But as minorities, many of us are lactose intolerant. Therefore, we suck at getting calcium, and therefore we're instantly at risk for osteoporosis. Or if you have a family member with osteoporosis, or if you're a small frame Caucasian woman, you're also at risk for osteoporosis. So those are the indicators. And then this is just re-emphasizing that this perimenopause is what people call the zone of chaos, that the hormones are crazy. And so testing during perimenopause is not useful. Because if we get a low estrogen, you could just be on a low. If we get a high estrogen, you could just be on the high. And so anyone that's trying to sell you a test for menopause other than an LH, FSH, but estrogen, progesterone during perimenopause is just trying to make money off you. Anytime somebody's making you pay cash, then there's a reason that the insurance doesn't cover it, because it's not evidence-based medicine, and it's probably not bang for buck.
Did you say something like a off-label? What kind of off-label treatment they do?
So they're doing the HRT, but they're doing it to prevent heart disease. They're doing it to prevent dementia. They're doing it to because when you take away the estrogen, your fat goes straight to your waist. So if you've met me in person, you would know that 99% of my wardrobe is skirts. And the way that I knew that I hit menopause is my waist disappeared. I went to see my doctor, and let's just see if you play it out in your head. 52-year-old woman comes to you, her waist disappears, her triglycerides shoot up. What do? My doctor, which I picked the best possible doctor I could find, because being an academic, I'm a snob. I checked her residency, I checked her medical school. I go see her, and she's like, oh, that's just old age. Go see the nutritionist and exercise more. And I'm like, I'm an obesity expert. People wait 6 months to see me. I know my diet. I know my exercise. I have changed nothing from the previous year. And I get old age, but I realize old age is a euphemism for menopause. And that, I had not changed my diet, done anything. And then the triglyceride shot up. But then I switched from birth control to HRT. My waist came back and my cholesterol normalized, but she also put me on a statin. And I believe in statins. So I was like, I'm not coming off the statin. I'll just stay on the statin. This is just showing you the geeky background of what happens and why the estrogen goes higher and higher sometimes in perimenopause is one egg pops and then your ovaries a little crazy. So another egg pops and then the estrogen gets higher. And so that's the luteal out of phase event. And so you have this up, 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 down, 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 and weird bleeding. And so on the left, you see here with birth control, your hormones are stable, and that mimics your hormones in your fertility years versus this chaos of perimenopause. And that's why birth control pill patching is the gold standard treatment for perimenopause. And so know that you can make periods optional. We talked about the weight gain, how the fat goes to your waist, but as an obesity expert, it goes to your viscera, which is around your heart, and to your liver, which horrifies me as an obesity expert. So if taking away estrogen puts fat in those bad places, I say put it back so that it doesn't go to those bad places. So you have a decreased risk of death. And it is part of...
You're saying this is a special symptom of menopausal symptom. If you stop the treatment, the fat goes directly to the liver and the heart. Is that
around the heart, around and in the liver, and to your waist. It's called central adiposity. And so this graph is showing you that part of this is, quote, old age, changing of there's more than just estrogen, progesterone. There's probably, growth factor and thyroid. All of these things are just shutting down because it's like, thank you for your service, go, and so we're seeing more fat mass as you age. And so you do need to change your exercise routine. You do need to change the way you eat. And on the next couple slides, we'll hit that.
I spoke with a person, body composition you're talking about. Her name is, she's a mathematician from the Naval Academy, from the United States Naval Academy. She's a PhD. She invented the body round index. She did a calculus on it and said that the roundness in the body, in the waist size, can determine not the BMI is a BRI. They call that is much more
Ah.
important. Is what it's
Yes,
saying.
no, the closer to central adiposity, the
Yeah.
greater the risk factor for bad cardiac results.
Yeah.
And so these slides are from Dr. Catherine Hansen, who you've had on here before. She's our old guard of menopause, but decrease lean muscle mass, increase fat mass. There's also changes in the gut microbiome, and there's also decreased physical activity from fatigue, work demands, mood changes. I think the next couple slides are kind of cool and new. So it's, these are the new kinds of exercises. You're not just trying to do aerobic exercise, which is what we tell people who are trying to lose weight, but you want to do resistance exercises to build your muscles. And I'm hearing you want to do something that you only can do 5 or 6 reps. If you can do 10 reps, that's too light. You want so much weight that you can only do 6 reps, because then you're stressing the system, you're increasing your muscle mass. And then there's SIT and HIIT, which is high impact intensity training, and then sprint training. And people say you need to do this kind of training every 48 hours. You need to give yourself 48 hours to calm down the inflammation from the exercise. And then plyometrics, or jumping, is for bone density. They've shown that if you're jumping or running, or like you see me, I'm just doing this on the Zoom on my chair. But I tell my patients, get a yoga ball and do this on a yoga ball, because the biggest muscles on your body are your quads and your glutes. That's just in general. But the jumping, the hitting, the gravity helps the bone density. And so sprint or HIIT training helps your type 2 fibers. And
So
after
they go for running. They need to go on running or sprint marathons or something. Is that what
Well,
you
no,
say?
the sprint training is just bursts of like really stressing your body out to the maximum that it can do. And with just 8 weeks, you decrease your visceral fat by 15%, and you decrease your fat
This
mass.
is nothing to do with the menopause. Anyway, all it applies to all humans, right?
All humans, but particularly menopause, because in menopause, we're losing muscle and we're gaining fat. And so we need to make sure we put that back if we want to live like a 40-year-old instead of an 80-year-old. And then, just as I mentioned, muscle resistance, and that will result in fewer menopausal symptoms and gains in strength. Quickly, the kind of key points I want to make sure people know about perimenopause, menopause, if you can go to the next slide, is that bioidentical, body identical estrogen is available in the patch, the spray, the gel. You do not need compounded. Compounded is not FDA tested, not FDA approved. And according to the American College of Obstetrics and Gynecology, there is a lack of high quality data on the safety and efficacy of custom compounded bioidentical hormone therapy. Compounded bioidentical therapy should not be prescribed routinely when FDA approved formulations exist. Anybody who's selling you compounded is just trying to make more money, because we have good enough FDA approved stuff that when you compound, they can charge you more and that expires. Whereas this other stuff lasts longer and has been tested and is very inexpensive compared to the compounded. And then definitely do not do pellets.
There's
People are
also a lot
looking.
of risk in the compounding because I've seen a lot of infections and all those things, right?
If you don't have a good pharmacy that you know and trust and has
Yeah.
been tested over time, that just spun up overnight to make Wegovy
Mhm.
Ozempic, then there's definitely that danger.
Yeah.
And then the next slide, I think, estrogen hormone therapy does not increase your risk of breast cancer. In the Women's Health Initiative, which was the
This
study
is
of
a myth up there, right? There is a lot of myth in this. Estrogen increases the breast cancer.
And so the Women's Health Initiative came out in 2006 and said, HRT causes breast cancer, stop the study. And if you actually pull the study, if anybody does statistics, which a lot of us do, we know that if the relative risk crosses 1, you would not publish that paper, and it is not statistically significant. And my friend actually pulled the paper, and I didn't pull the paper. I went to UCSF. I thought my professors knew what they were talking about. The range is 0.83 to 1.92. Even a kindergartner can tell you that crosses 1. And if that crosses 1, then it's not statistically significant. And in the estrogen only group, which is a group that had no uterus, so they didn't have to give them progesterone, they actually had 37% decrease breast cancer. And those that got breast cancer, 44% decrease death from breast cancer. So we really think that it's the synthetic progesterone that increased the risk of breast cancer in those that had it. You can also add back progesterone. It helps with sleep. And we now prescribe bioidentical progesterone. And there's been no cases of increased breast cancer with bioidentical progesterone, which again is not compounded, is FDA approved, is very inexpensive, like $15 a month. My favorite books, The New Menopause by Dr. Marie Claire Haver. She has a great following on social media, but she teaches a lot there, and I really like her. My only negative is she'll push a lot of supplements. And so I would say that anybody who's pushing supplements instead of HRT, ask them, has this been put up against estrogen? And and the answer will be most likely either no, or if it did, HRT beats any supplement. However, if you have a contraindication for estrogen, then yes, do everything you possibly can. And certainly there are other supplements that can help with other things. And follow us on social media, Pandia Menopause, if you want to learn about menopause. Myself, Dr. Sophia Yen, and then Dr. Catherine Hansen, who helped supply the more exercise slides that you saw.
You did a comprehensive, first time I see that, very comprehensive thing you did. They're very good. It's very first time you did there is a lot of misunderstanding about menopause, even for women, man, zero knowledge. What men can do, then I will hand over to the Jennifer. But what is the man can support in this area?
I think it's wonderful that you as a man have chosen to highlight menopause and to learn about menopause. And I believe any educated person should. So now that you've heard about it, share it with all the women in your life. As my dad says, and I wear a uterus necklace, we all came from the womb. We are all touched by the womb. We have a mother, we have a daughter, we have a nephew, a niece, a grandchild. All of us are connected with somebody with a womb. Share these books, share this talk, share this knowledge that women need to #stop sucking it up. If you're having hot flashes, night sweats, painful sex, any kind of menopause symptom, get it treated. We have medications, and that the estrogen will not, in HRT, will not lead to breast cancer.
So Jennifer, do you have, you must have a lot of questions, but give me one or two questions to Dr. So as a woman to ask is better. Yeah, go ahead, Jennifer.
I do have two questions, Dr. Yen. So I am always curious, what is the blood test that you should get? And then the second part of that is, how do you know what doctor to go see specifically for you're actually in menopause? So you've got several of the conditions you mentioned, maybe none of the symptoms, but you have the fat issue, and you've changed your diet and you've exercised and you all the things, but you've not done any of this biohacking. You haven't done any HRT. And how do you know who to go to see really what that is? I mean, and is there a blood test to get to see what numbers do I need to know to show me what I need to make the next step?
Yes. So, as I mentioned, if you're in perimenopause, there's really no point getting a test. But if you're having these constellation of symptoms, we always want to check a thyroid test just to make sure that you don't have hypo, which is low thyroid, low metabolism, gaining weight, depression, being tired, versus high metabolism, which is your heart racing really fast and sweating and other things. And we also want to make sure you don't have any tumor or anything like that. So your general practitioner can rule out that basic part. The hard part, like I said, there's only 3,000 Menopause Society certified practitioners in all of North America. So that includes Canada. And so you can go to menopause.org, find a Menopause Society practitioner, or Pandia Health. We can prescribe in 15 states, which covers 70% of the population. And we encourage birth control and menopause tourism. So, example, we're not in New Jersey or Connecticut, but we are in New York. And who in New Jersey and Connecticut can't get to New York once a year? Just put your foot in New York and be like, I'm in New York right now, and I'm paying my money, and I'm in New York. And then legally, our New York doctor can take care of you, and then we can deliver to all 50 states. Our pharmacy is licensed in all 50 states. But if you can't access us, there are other companies out there as well. But just make sure your doctor is up to date, because like I said, I chose the best and the brightest, and I was gaslit. And then I spoke to somebody who was the former chief resident at UCLA in family medicine, and she was still spouting the old routine, lowest amount of estrogen for the shortest amount of time period. But now we know, if you're up to date on the latest recommendations, that it's not the shortest amount of time. It's whatever's necessary to cover. And then if you are getting a test after menopause, after your final period, to confirm it, you could check, I believe either an LH or FSH. But again, if you had your final period and you haven't had one for a year, then only if it was like early, then I might check like a prolactin just to make sure you don't have a tumor. Again, thyroid for other things, but really not so much. Once you're on treatment, some people will check an estradiol level, simply because if you're using the patch, they've been shown to have variable absorption. And so they want to make sure that you are absorbing correctly. But I do feel right now we don't have the science to tell you, again, when menopause is happening. We can only tell you menopause has happened 12 months after your last period, unfortunately. But we can see the trend going there with the LH and FSH.
After I finish the presentation, Jennifer, you can come back and ask a lot of questions. Let me present, very connected with this kind of a relationship with all these people. These three people, there is a taken in the Philadelphia. This one photo taken in 1885. This October 10th, Dean's reception. They're all 19 to 29-year-old things. 19-year-old there's a left woman from India, the one from Japan, Syria. They're all foreign students, came to study to the United States in 1885 to study medicine. That's what I'm presenting. So very quickly, a lot of slides. 1885, I wanted to tell you how the America looks like. Statue of Liberty just arrived. AT&T Incorporated. I just want to give you. Transportation is a horse buggies. There is no cars. There is no automobiles. Slavery at the end. It's the end of the slavery. No indoor plumbing in 1885. It's all. Then there is a Rock Springs in Mary, Wyoming. There's Chinese people who were killed. Worst racial violence among Chinese workers. That is in the 1885. America was going through. Edison was trying to do. He invented the electric bulb. He was putting new lines, electric lines in Rochelle, New Jersey. That's what he's doing. He had $1 million at the time. Can you believe that? That's like $200 million now, probably $500 million. So decision 1885 in National Board of Health. There's no NIH. That's called. There's no NIH. Actually, the National Board of Health is called. Up to 1883, I think NIH came after that. Cholera, typhoid. These are all tropical diseases are also here. Malaria, yellow fever, whooping cough. Sophia knows a lot more than I do. These kind of problems. So they used to treat pain with opium, cocaine, fevers with antipyretics, bark, wood box, skin is a camphor. I see some people even treating nowadays with a camphor. Johnson & Johnson introduced in the 1885 $500 investment. They started the Band-Aid. Robert Wood Johnson, the three brothers, I think, they started together in 1886. So during the time 1885, by ship, through Christian missionaries, the woman from India came in. Her name is Ananda Joshi. She was born in 1865. She was born in the western part of India, Pune, India. She came to the United States through Rochelle, New Jersey, where they're putting electric lines. During first electric lines were implemented, she came to that city, actually. She had a host family there. Sabbath Slomboli she's from a Kurdish Jewish woman. She came from Damascus, Syria, to the United States to study medicine. Kai Wakami, she's the oldest woman among all of them. So she came from Tokyo, Japan. They all three ended up in this place, in the first women's medical college of Pennsylvania, Drexel University. Dr. Ann Preston started it. That's a building. Looks like a huge building, right? I don't know. We all think so. It is a microscope. Just I think they started using a microscope during the time. So it is a foreign student using. The surprising thing is the material medica is the courses I saw very surprising. I saw when my son is taking pre-med courses, they're all same. Even now, 1885, they're taking the same kind of classes. It's not much different, but more advanced. So all the girls, that's the first women's college. So they're having a lot of fun. See that they're playing with all the girls, as usual, playing with the skeletons. This is now it's a Drexel, that first university of Women's University of Pennsylvania became the Drexel campus actually. January 4. So what a C-section debate was raging at that time, 1885. First successful cesarean section in years, no anesthesia, no sterile. Can you believe that? No anesthesia. So, we'll ask Sophia about that. She wrote, that Ananda Joshi, she's a 20-year-old. She's a prolific writer. I cannot believe how well she writes. She wrote a book, kind of a letters to Indian magazines, as the importance of obstetrics can be measured only by the value of life and death, by life and health, and both being of a paramount consequence, it is deserving of a most careful study. What she was saying, just don't dismiss everything, Ayurveda and all those things. We need to pay attention to and study more, everything and more. So that's a first foreign medical graduates. These are all three women, our first feature of the foreign medical graduates. That's colored. RTVAI did the coloring. But Queen Victoria gave, after the graduation, she was graduated in 1886. She graduated. Queen Victoria gave her complimentary things, and then she returned to India. She died with a tuberculosis. Unfortunately, she died very young age. Life after Sabbath Slomboli, she went to Egypt after that. We don't know a lot about her. Actually, there's not much written about her. But she also did remarkable things for the woman up there in Egyptian woman. So she moved from Syria to Egypt. That's all we know. Wakami, her life was documented quite a bit. That's what the understanding is. She started a Zaiki hospital in Tokyo, but she was also discriminated because she became a Christian, and in Japan that is a big no-no at that time. So I don't know much about it, but she lived a long life. She was 90 years old, and 1941 she died. So it is but even though 25 years old, this woman, she wrote because of the America fascination with the Indian clothes, Indian jewelry, all those things. Caroline Doll is one of the socialite from Washington, D.C., wrote a book on autobiography of Ananda Joshi. She wrote, because Ananda Joshi documented a lot of stuff. She wrote a lot of things in her own language, Marathi, Indian native language, one of the dialects of India, and then she wrote in English, beautiful in English. She wrote also she wrote a thesis on the Hindu woman about the OBGYN things. Caroline Doll is a Washington socialite. She met Ananda Joshi, and she invited her to Washington. She invited a lot of people came to see Ananda Joshi during that time, actually. So recently there was a Professor Sarah Roskapit. She is also she wrote a thesis on all these women who went to the women physicians of the world, international, so first women's medical college of Pennsylvania. She wrote a nice things about that. So there is right now Indian doctors in the United States 100,000 plus, according to the American Association of Physicians of Indian Origin organization, and Syrian physicians are 6,500. Japanese, we don't have much, but there is a Japanese Medical Society of America is there, Syrian Medical Society there, American Association of Physicians of Indian origin is the largest organization with ethnic organizations. These are all. So if you see shortages in ES, because I want to talk about that 1 minute, maternity care it's a maternity care deserts. That's what they call. There is a lot of places. 1/3 of the counties in the United States, they don't have OB care. I used to provide ultrasound services in Georgia. They were ninth month. They didn't know they have a twins because they don't have access to ultrasound. They don't have access. Rural Georgia is unbelievable. So Alabama, Texas, Georgia, Alabama, Tennessee is really, really struggling situation there. 2.2 million childbearing age women without essential services, OB care. Think about how much we care about our women. Pediatrics, Sophia is a pediatrician, so I got to do that. 13,000 by 20, that's a shortage. Worst is pediatric specialties. That's a 40% vacancy in residency. Sophia, can you believe that? Is a 40% vacancy in residency slots. I don't know why they don't give it to people. There's so many people waiting for residency. I don't understand this politics at all. And so the California is one of them. Is surprisingly the pediatrics shortage area. I place a lot of doctors. I used to place a lot of J1 visa doctors and shortage areas in Bakersfield, Fresno. I did a lot of those places. Really, I placed a lot of rural areas, Georgia, Alabama, Tennessee. I placed a lot of doctors. This country was me. More than I owe them. This country was me. I placed lots of doctors, saved a lot of rural women in this war, both black and white, all races. So Connecticut, actually, there is another one, much more bigger shortage. I used to do a lot of radiology stuff. So radiology techs, 81% medical facilities complaining about radiology techs. Actually, Connecticut, they put a task force to address for the radiology techs. So woman, we need a foreign J1 visas, a little bit for these techs at least, and fill up this. We don't want to give it to foreigner. We have a lot of people in this country. My son, Sophia's children, my children, they're all kids. You go and study this kind of things. So you don't have to go outside. But techs, we need it. Definitely, we need this. There's a memento. These are the beginners of this revolution. These three women. So Edison became a $40 billion company. Johnson Johnson, $400 billion company. Think about that. They've grown. But these are the associations, the ethnic associations in this country. I didn't see Taiwanese anywhere, but I don't know is a Taiwanese medical association there or not.
I just came from the North American Taiwanese Medical Association. So it does exist, but it's small.
Yeah, I like small ones. Actually, you can buy. That is the thing. Thank you for watching. Tell us now a little bit. The woman, the practicing these kind of things is a menopause practice. You need a lot of specialties, a lot of studies. That it takes a lot of energy. You need to assemble every resource in the planet to address this kind of a huge problem of menopause or OB care or GYN care, any care. It requires a massive amount of resources. We need all help. I don't know why we are cutting down all the people now. That doesn't make any sense. So tell us a little bit, Sophia, what is the Pandia Health that's trying to do and address using a technology?
So we've been around for about 9 years now. And for the first 8 years, we were focused solely on birth control. But as I hit menopause, all my friends are like, menopause. And I'm like, yes, I will find the best treatment for me and I will share it with the rest of the world. And we were so privileged to pick up two of the OG old guard menopause, Dr. Hansen and Dr. Culver, who each have 20 plus years experience as OB-GYNs treating menopause. And I was like, you are leading our menopause team and you will train all of our physicians to provide amazing care like you. And all of our physicians can consult you if they have any questions. So for our birth control patients, we see them within 1 business day. For our menopause patients, it's 3 to 5 in case our doctors are like, let me consult Dr. Culver and Dr. Hansen before I get back to the patient. Know that it's asynchronous, so you fill out a questionnaire, but then you have unlimited direct messaging with a physician back and forth for any questions. And it's only $35 a month, 1 year subscription for menopause, $35 once a year for birth control, because we didn't want anybody dropping off our birth control because they had side effects or whatnot. But we have a great algorithm for picking the best first birth control pill, with 93% of our patients happy with our first pill. And then we can prescribe in 15 states. I'm going to read them off: Arizona, California, Colorado, Florida, Georgia, Illinois, Minnesota, Michigan, Nevada, New York, Ohio, Oregon, Pennsylvania, Texas, and Wyoming. So if you didn't hear your state, if you can get to one of those states, or happening to be visiting, or you're going to go to Vegas or one of the Disneys, or if you're going to South by Southwest or New York, as long as you're in that state, fill out the questionnaire and say, I'm in that state, then legally our doctor in that state can take care of you. And then we can ship to all 50 states. And you just got to get back to our state, one of those states, once a year. Or if you all want to invest, Pandia Health is always taking investment. Hit me up on LinkedIn and I'll tell you how you can. And thank you so much, Romana, for posting all of our socials that are out there. I have to warn you that the last one is my radical political one and does not reflect the opinions of Pandia Health. Is only my personal.
It's okay. I like, nothing wrong. You need to be expressive. So, Instagram is the most important one for the birth control pills. And menopause is probably all the Facebook, and that's a menopausal people. So you can do both. So let me ask, pandiahealth.com, right? The website is pandiahealth.com, right?
Yes.
So Jennifer, you have any last questions you can ask, and then we can close the deal after this. So go ahead again, Jennifer.
I was just following up from my follow-up question. Say you are past 10 years post-menopause. What do you suggest for those women who still have some symptoms, some things, not all, maybe one or two, and still struggle with, say, like I had mentioned, extra weight around your waist?
Yes. So I would say that we didn't discuss, and exactly as you alluded to, there's something called the timing hypothesis. We now believe that if it's 10 years after your last period, then during that time, your arteries have turned bad. They're hard, they don't dilate, they fill with cholesterol. And if we were to add estrogen, then that is a clotting thing. And then you'd have a heart attack or you'd have a stroke. And so it's a risk-benefit ratio. How bad are your symptoms? And there are non-estrogen options out there. So there's something called the selective estrogen receptor modulator, which is actually an anti-estrogen at the breast and a pro-estrogen in the uterus and vagina area. It's just much more expensive and may not have all the other kind of benefits out there. And then we also have shared decision making. So if you're 10, 11, 12, 15 years out, but your cholesterol is perfectly normal, you don't have high blood pressure, you're not at risk for a heart attack or stroke, you've had a cardiac CT scan looking for coronary calcium, that's the new hot thing, and sometimes it's covered by insurance, sometimes it's not. But if your arteries are clean, then a doctor will probably be fine starting you up on estrogen. But if there's like clots and stuff, then we'd be like, maybe not. And then know that vaginal estrogen, it only works for the vaginal area. It doesn't have the systemic body good effects of bone, brain, and redeposition of fat. But if you have, symptoms in the vagina and urinary, does not have systemic effect at all. So the doses that we use in the location is very focal. And so even those with breast cancer can use the local estrogen, just not the systemic estrogen.
Both you are great fans of MedBricks, and so final before closing, say something about what do you think of my presentation and a lot of other presentations. Sophia, you've been on this podcast several times, so let's start with that one with you.
I want to say, thank you so much, Ramana, for having this platform, for highlighting different physicians and their work and the information they want to share with people. And I always love your history bit afterwards. I personally, as a student growing up, hated history and would always fall asleep. But everything that you've presented has kept me awake, which is, if you ask my professors, quite a thing to keep Sophia Yen awake, and too interested. So I want to thank you for the service that you're providing the world.
Jennifer, you're part of this kind of thing. He helped me during the pandemic times. Nobody was there, so she was knocking my internet on the Zoom sessions. We did a lot. Before I met Jennifer, she was helping me to write a book, and then the podcast is based on that book. Actually, I did all these historical figures and everything I did. So tell us a little bit about that journey up to the point before I close.
Yeah, Ramana, it was wonderful. I mean, writing the book together was great. I love all these topics now that the podcast has really grown into something that really does bring to the forefront a lot of different topics. And I'm just grateful that you do take the initiative, because it's not easy to just put on a podcast. He's not just flipping on a camera and putting this together. So the thoughtfulness that you do and you take for each and every person that you have on here is really remarkable. So thank you, Ramana, for all that you do.
Thank you so much, Dr. Sophia Yen. This is a permanent place for you, MedBricks. Thank you. You're always welcome. And you're doing MIT. Tell us a little bit about the MIT live sessions here. You're announcing. Can you
yes.
before we close? Yeah.
So MIT has a digital health series, and we're doing live in-person gatherings in Silicon Valley. If anyone's interested, hit me up on LinkedIn, and we can send you these events. The next one we're going to do is going to be menopause, and our parody or whatever is to test or not to test. That is the question, because we have two companies that are coming, one that does a blood test and one that does a dip urine test. Very expensive, not covered by any insurance, but for people who want to do the quantified self. And then I'll repeat my Menopause 101. For any Asian American women that we're doing an event down in Los Altos this Sunday at 2 p.m. Hit me up and I'll send you the invite for that. Again, it'll be similar to what we did today, but an hour. And I also have a pelvic therapist who's going to teach about mainly the way to prevent osteoporosis. She believes it's 100% preventable as long as we do weight-bearing exercises and build our muscles and get enough protein to eat. So I hope that also answers Dr. Rajesh Chander's question that we see pop up here. So hit me up on LinkedIn if you want any of these events that we're doing. And thank you.
Are you doing a live streaming on this one? Other people can watch that? Are you doing a live streaming on the MIT thing?
So we usually record it and then post it afterwards. So Google MIT CNC, which is MIT Club of Northern California Digital Health. And I think you can find our previous talks. We just did an amazing talk on dementia, but unfortunately, the person didn't want us to record it because she was afraid she might have released some of her proprietary stuff. But most of the other talks we almost always record and put up on YouTube. So check YouTube for that.
Thank you so much. Thank you. Always fun to have you. Thank you so much. Sophia, thank you. Sophia, Dr. Sophia Yen. This is Jennifer Niemeyer, good friend of mine. Thank you for joining. Good night, all of you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it